Morning.
Good morning.
Morning.
See if we're expecting anyone else.
I think it's just Rebecca.
We'll just give her a minute or so. Yeah, still a minute early.
And Fiona, who's doing the story with Katie. I suspect Katie is hoping Fiona's going to be joining.
Very much hoping Fiona joins, yes.
I'm sure you won't be left
If not,
on your own.
I'm sure I
Katie.
can get through it.
You could. You absolutely could.
Well, on the basis that Rebecca might be held up for other work matters, let's make a start. Welcome, everyone. I know that we've got two deputies today because of apologies from both Tolu and Teresa. So welcome both Gary and Amanda. Looking forward to having you part of the meeting, and do feel free to contribute and join in wherever you feel appropriate. Julie, everyone, do we have any declarations of any other business for today's meeting? No previously notified to you, Julie?
No.
No, that's good. Declarations of any interest, either meant to the register or for today's agenda items? No, not shaking heads. Otherwise, then on to the minutes of the last meeting held on the 8th of July. Is everybody comfortable in terms of the accuracy of those? Morning, Rebecca. In which case, the action log and matters arise. We've got a number coming up from there. Any that we need to be aware of, Julie, that aren't covered?
No, I think it's all in hand.
Okay. I did meet with Kate Penhaligon in terms of the research, and she's going to be letting us have some crib sheets and notes for when NEDs go out on visits or 15 steps, etc. So we'll pick that up when that has come through. Otherwise, on to item 6 and today's patient story. Debbie, do you want to give an introduction to this?
Yes, sure. So thank you to Fiona and Katie who have joined to do a story. It's a bit of co-production work actually in terms of the Children in Care team and health assessments, but I will hand over to Fiona, I think, who's going to lead this for us. Thanks, Fiona.
Thanks, Debbie. Hi all. We were just going to give you a quick overview of the Children in Care team and how we came about with this project. I do believe, Mark, many years ago you came out with us for the day. You went out with my colleague, Lynn Smith, a long time ago with the Children in Care team. So, but if I just give you a quick overview, Katie, we just got a very short PowerPoint before we show our co-production video that was made for us. So if we can just share that, Katie's going to be my IT person.
Did you want me to share the presentation?
Yeah, please, because it's just got some figures on that we can show. So basically, we are the Children in Care team. We're quite a small team. There's 17 of us in total. We've got 9 clinical staff, so 6 specialist nurses and 6 nurses for Children in Care. And we've got 6 administrators within our team who all have a specific role with regards to arranging health assessments. So initial health assessments or review health assessments. And then we've obviously got head of service and myself. I'm Fiona Nyquist. I'm the team lead within the Children in Care team. Sorry, I should have introduced Katie. Katie is one of our specialist nurses she covers West Berkshire. And Katie was very involved in this project because she's very good at IT and I'm not quite so good at IT. So that's us as the team. Katie, it's not sharing. I don't know if it's coming through.
It's still trying to load. I've got a very slow Teams this morning. Sorry, bear with me 2 seconds.
Okay, I'll talk through as Katie's loading it. So basically, our main responsibility as a team is to oversee the children in care within Berkshire, that their health needs are met. So this is a lot of joint working with our partner agencies, particularly Children's Social Care. So I guess in a nutshell, our responsibilities are arranging statutory health assessments, delivering training to staff that complete statutory health assessments, but also to foster carers within the 6 local authorities that we do twice a year to support them. We contribute to safeguarding forums, foster panel, corporate parenting panels, and we're a resource. Basically, we're the resource for any child in care and any professional that's working with the children in care, any children in care across Berkshire. So I'll let Katie, there you go. So we have this statutory duty to offer health assessments every 12 months for a child who is over the age of 5 and every 6 months for a child who is under the age of 5. So when a child comes into care, they have an initial health assessment with a community paediatrician, and then after that, the health assessments are taken over by our team. But this is also, our nurses complete the over 16s, but we also have the specialist school nurses, the health visitors, and the youth justice physical health nurses that will review health assessments for our children and young people in care. So we cover quite a wide area. Us as a team go out within a 20-mile radius. Any child placed, so any Berkshire child that is placed within a 20-mile radius of the Berkshire border, we would go out and see. And as you can see, it's quite a vast area because it's 20 miles as the crow flies, not as we drive. So we would do that for any child that is 16 plus and any child younger that is, as I say, placed outside of Berkshire by a Berkshire local authority. I'll just give you a quick view of the figures. These are the number of children in care in each area, as you can see. We also support the hosted children. So these would be any children placed in Berkshire by an outside local authority. So the total number of children as of 1st September in Berkshire are, as it says there, 1,374. And we don't do all these ourselves, obviously, but we manage approximately 1,450 RHAs a year completed for these children and young people. So how did our project come about? Basically, we were fed back by the children and young people. Our previous RHA summary report was very much a report. It was a holistic health assessment where we'd speak with the children and young people, the foster carers, to get an overview, an overall holistic assessment of their health. The young people fed back to us that they felt it was too detailed, too time consuming. Bracknell Children in Care Council talked about the fact they didn't like being asked to be weighed and measured. They didn't like some of the personal questions. So we developed a project group which consisted of us, other members of BHFT within health visiting and school nursing. We also went out to Solutions for Health, which are the health providers for Slough. It's now HCRG, and the same for AFC. And got their staff involved. So we did it as a very much a joint piece of working. We got feedback from social workers, and we also got feedback from the children and young people themselves. We reviewed all the feedback, and we then created a new, more engaging child-focused form. We then here's how it went. We then, July 24, we went to the Children in Care Council, had a participation day where there were 5 of the local authorities there with a number of children and young people, where we went to feedback our draft forms. To do this involved playing rounders because they wouldn't talk to us. These young people are lovely, but that you go their way. So we had to play rounders before they'd give us any feedback. What they did was engage beautifully and told us what they felt. So we then updated the forms, went back in October and shared these. And then in the November, we launched our final pictorial RHA. This makes it sound very, very simple, but this also involved training of the staff completing the RHAs with the new form and how to do it. And it was a process that we went through to make sure that we got everybody on board while we were doing it. In May this year, we reviewed the forms when they'd been running for about 6 months to make any further amendments. And we went back out and did some more training to the practitioners that were completing these forms. I make it sound really simple. It wasn't, Katie, was it? It wasn't as simple as it sounds, honestly. So that's how we got to where we got to. These are the forms that we've created now, bearing in mind our previous forms were very much just written reports. So these forms are now very much for the young people to complete with us, or to complete, we complete for them, but they fill them in. They pick the topics that they want to discuss in an order. And we've got one for children with additional needs. We've got 2 different ones for for the younger group, which is this one here with the photos. And on the next slide, we've got one that's got more of the emojis, depending on what the practitioner feels they're engaged with better. And this is our one that we tend to use for the young people, the older sort of 11 plus, which is a bit more like what they called it, the Monopoly style. So these are the forms we've come out with. This is just a quick example of one that when a young child engaged with in completing the form. So we get much more of the child's voice. So if at any point in their life they want to look at these, it's really lovely that they can see their input. Now, the outcome from this was the young people then made a video for us to use when we are training practitioners that are doing the RHAs. So very much a joint piece of working. We're using it within our training. We're also going to use it within the safeguarding forums. But this has taken a bit of a life of its own because a lot of people are wanting to see this video. And it's Katie's going to share it now so you can watch it. But it's very much about what the young people want from the practitioners that are doing the health assessments. And it's very much shows you said we did in a very joint working way. So I'll just let you watch. I've really whizzed, I'm really sorry, but if I let you watch the video and then any questions we can then pick up. But I didn't want to run out of time so you couldn't watch this bit. So is that okay, Katie? Yeah.
For the nurses and doctors, you need to be more funny, you need to be yourself more, get to know the people that you're working with more, and yeah.
I think to make a good nurse, you need to know whether they're angry, sad, happy. So for me, when I'm sad, I'm like this. But when I'm angry, I'm like this. And when I'm happy, I'm like this. To know how they feel before you just jump right into the assessments, being like, oh, do you take drugs? Before you know they're unhappy. So you need to ask them how they feel, and then you need to bring fidgets in case they're sensory for them to focus. And you need to give them a choice of what they do. And the last thing I say is just be understanding, be kind, because I need that. If I don't have that, I'm like this.
When they're not like judging you, they're very easy to connect with, very conversational. I like it when it doesn't feel like I'm being judged in any way, and it's, yeah.
I like it when the conversations aren't forced, like when they sit down and, you know, actually try to get to know you a bit and they get to know what you like. So it's not just, you know, they sit down, right, so how are you? How's your mood? How's your sleep?
Yeah.
Calm down a minute, please.
I like how when it's more of an open conversation, like they're treating you more like a person than a patient.
Why is it important to listen to these changes? Short answer is so the young person you're talking to is comfortable. Long answer. Everyone has different experiences. Some people have known their school nurse for quite a while, whereas some others are new to the school nurse. So it's important to ensure that the young person is comfortable, so when you're talking to them, they'll open up truthfully. My own personal experience is that I felt very uncomfortable, so I'd often lie in hope I can get out of there quicker. I didn't like how they'd come into school with this big green box, and we'd walk past all these students, and like you'd be wearing your lanyard, and it just draws so much attention, and it's really abnormal to be weighed and measured. I understand it's important for some people, and maybe like it will benefit them. For me, this was not the case. If anything, it caused me stress. I understand like it was optional, but it felt like I had to do it because like the person was already there carrying this big box around. But then when I was weighed, my school nurse at the time said how I was below weight, but then said it wasn't an issue, but then proceeded to want to weigh me again. They made this big thing out of it, but also claiming it wasn't that big of a deal. So there was like a massive, maybe not conflict is the right word, but it kind of felt like one. So it made me like question my weight, because she couldn't be straightforward about whether if it was something to worry about or not. I think that's why it's important, like, these changes in order for the comfortability. Especially this school nurse who I already felt uncomfortable with would proceed to ask about my sex life. Bear in mind, I'm like 15, 16-year-old girl. I don't want to talk about that to it was a woman who was talking to me that I met twice. It's not normal. And I didn't know that I didn't have to see the school nurse in school. I didn't know I didn't actually have to see her in the first place. And I didn't know I could reject talking about certain things. So it's important to highlight these when talking to your young person. So if they don't want to discuss something, then it's fine.
Thanks, Katie. So what the young people did was produce this video for us, which we've incorporated in our training that we now deliver. They delivered it to us and to some of the community paediatricians and social care workers. They delivered a training session to us and have allowed us to use this moving forward. And what this whole project has done is raised, it's very much a use that we did. We've very much listened to the young people. We've worked with the young people, but also with our practitioners to try and get a balance of the right form that allows us to get the information we want and respect their wishes. But it's really proved a really positive piece of joint working. I've thrown a lot of information. I'm really sorry, but I was conscious I didn't have very long. So I just wondered if anyone had any questions about what we've done, about children in care, or have I blindsided you all?
Yeah, Fiona, thanks ever so much, and Katie, for your presentation this morning. It's a really powerful example, that video, of what co-production can create if we really sit down and listen to the people that we're working with. And just before I hand it over to Aileen for her question, I just want to say I clearly remember the day that I came out with your team and spent the morning in a community centre with a number of the foster carers, and then had the benefit of going into the home of one of the foster carers and listening to that health assessment. And your team member who I spent the afternoon with was quite critical of the paperwork because there was so much to fill in, and it was very much a tick box completing documentation exercise. And to see those examples that you've given this morning, which are so much brighter, more colourful and user friendly, is tremendous. So thank you very much for that.
Thank you, Mark. And I think what's happened over the years with our previous forms is with CQC and recommendations, they kind of got longer and longer. So it was the right time to do something about it. And these health assessments, I mean, Katie's played football, completing a health assessment with a young lad, or fixed a motorbike. You know, we'll engage in any way we can. So thank you.
Thank you. Aileen.
Yeah.
Yeah,
Katie,
hi.
yeah.
Great presentation and great video. It was really, really interesting to watch. What came across to me, what struck me was I mean, there was the personal questions bit. Obviously, that was a big element, but the environment. And so you kind of answered my question. My question was going to be, what sort of environment now do you most commonly go to? But you said about playing football and renting a motorbike, I think you just said, playing rounders. So how, you know, what's the limit of what you do? Do you still see some children in the schools?
I think we're quite lucky in our team because we have that flexibility, and the way we're commissioned, it does allow us to see them in, you know, within reason where they'd like to be seen. But there's also, we can go slightly later if they're, because obviously we're seeing the older ones, we can go slightly later if they're in college or such like. So Katie, I'll let you, because you actually do more visits than I do. So yeah.
No, that's okay. I think what these forms have allowed us to do, because we found out that some school nurses were doing the health assessments on their laptop, because that was a really good way for some children to engage with them. So these forms are now adaptable via a Word document, so they can be typed on as well, which is brilliant for practitioners, but also for young people, children, carers who might like to type and get involved, you know, thinking about neurodisability, dyslexia, things like that. The typable form is much easier for practitioners and some young people to use. The older ones we can see in coffee shops if it's safe. Obviously they quite like to write their own personal information on those forms, so it, from the outsider looking in, it just looks like a potential auntie is taken, you know, someone out for a coffee. So that's what they really like. They really like that this engagement has now unlocked them to be in more comfortable situations. But as long as the children are safe, we've done a risk assessment, we could end up doing anything really. Another colleague goes to the skate park and answers a question every time a girl does a flip, or, you know, a safe flip. So we very much do work with the young people, and some young people like to be seen in school because that is their safe place. So it's all about just having that conversation and allowing options, really.
That's amazing, because you probably get so much more out of them, don't you? And
Absolutely.
Probably the most important part of my question is, who won the game of rounders when you played the rounders?
I didn't, Aileen, because running in flip-flops is not my forte. Okay? Running full stop is not my forte. No,
okay, thank you.
Sally, your point.
A very interesting presentation. One of the things that struck me was you didn't seem to have so many young men engaged in the presentation. Are they more difficult to deal with? And the other issue I wanted to ask is, I'm very aware that children, looked after children, do poorly poorly as adults generally, and I wondered, you know, what the mental health dimension was of the assessment and the mental health expertise within the team to sort of identify that early, perhaps.
Yeah, and there were young men involved. It's interesting you say that. There weren't many young men in the actual video, were they? But when they did the training package to us, there were young men involved in that. But yeah, whether they weren't so keen to come forward, each council has a children in care council where they have obviously the children and young people in care. In Bracknell, for example, it's called SILSIP, Say It Loud, Say It Proud. In AFC, it's called Kickstart. I can't remember what it's called in West Berkshire. It's gone out of my head, Katie. But so they do have a mixture of male and female representatives on there, and they're usually probably from the age of about 10 and upwards. There is an aspect of, Katie, over to you actually, you form-wise, mental health-wise.
Yeah, of course. So each child, when we're looking at doing their review health assessment, the social worker each year, from the age of 5 to 16 or 17 in some local authorities, need to complete a SDQ score, which is the Strengths and Difficulties questionnaire. Right. Each local authority now have a wellbeing triage meeting as such, where particularly in West Berks, we have the Children in Care CAMS team come. So that's a brilliant new service that we have on our side that can support network meetings, which is a very quick referral from the social worker for a young person that we might have concerns about. There's no upper age or lower age limit. They can do one-to-work with the children or the young people, but predominantly they look at the network to help support how the people around the child can support that child. The wellbeing triage meeting has the Emotional Health Academy attend, Children Care CAMHS team, supervisors and social workers, independent reviewing officers, personal advisors, where we look at all the children who have a risk rating of amber or red. So their strength and difficulties questionnaire has highlighted that they need further support. So that is one way to be able to signpost young people to get early intervention help. And just by having a conversation about how they're feeling, often sort of can lead you to those questions. And then we would then either support a referral into the Children CAMHS team, or just have that catch up with a social worker to raise those concerns and make sure that the right pathway is followed to support them as well. There's information we give them, such as the Tell Me app, the CAMHS 24-hour crisis team numbers. So there's lots of information that we do give them, but ultimately we'll have a catch up with the social worker to ensure they're supported that way.
Thank you very much.
Does a similar meeting, don't they, Katie? So yeah, we'd support them on that path, whichever pathway they needed. Yeah.
Right. Thank you.
Thank you. So Fiona and Katie, thanks ever so much for your presentation this morning and bringing this to life for us. It's so important that we get the opportunity to listen to people like yourselves that are dealing with people on the front line. I'd also encourage members of the non-exec team that if you ever do want a really fulfilling and satisfying time out, I'm sure that Fiona won't appreciate you all just hanging
on the same time.
But it really is a wonderful insight into the care and attention that they give to not just the people that they're supporting, but also the foster carers as well, and the support that you give to them and the safeguarding role. So thank you ever so much for that. It's really appreciated.
Thank you.
Can I just say something very quickly, Mark? Sorry, just to let you know that the school nursing team are currently looking to use these new pictorial forms as part of the child protection assessments and conferences, and also the youth justice team are now adopting them to use as their physical health assessments for young people, because they've had really good engagement and feedback. So we're just hoping to carry on working with these services to ensure that we get the best feedback from our young people and children and carers as well.
And finally, on a positive note, we've had out of area wanting to copy our form as well. So Gloucestershire's come back to us, Isle of Wight's come back to us. So we are trailblazing in the children care form area.
That's tremendous to hear.
Thank you.
Thank you both very much.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
So moving on to our patient experience report, Debbie, I'm just wondering, whether taking on some of the learning from the last, whether I should be asking you if you're angry, sad or happy today before you give this next piece, but over to you and the patient experience.
Yeah, that might open up a whole can of worms, Mark. But the patient experience, so it's our standard report. We have put in it a little bit around some of the work we're doing around with our lived experience workers, because that is a growing workforce across the organisation. We've got about 33 lived experience workers in 7 of our mental health services now, and that is another rich way of supporting some feedback and understanding around how services are perceived. So we have added that in there. There is a typo in here that I noticed after I'd sent to Julie, and she has got a corrected report. We are at 54% of our complaint response, complaints being either partially or fully upheld, not 84%. That would be really high. I had a slight concern when I saw that, but it's definitely 54%. And we are creeping towards the 10% feedback through I Want Great Care. We were at 8.8% in June. I have added into the highlight report, because I know it's one of the questions that get asked a lot, a little graph that talks about us getting 91% of respondents do give a reason why they've rated, which I think is really important, because that is showing this isn't a tick box. People aren't doing a hurried quick tick a couple of boxes. The vast majority of people are taking the time to explain why they've put what they've put, and 79% of people are saying there's no improvements needed, but others are putting the improvements. And I think that is quite important, because one of the big things for me is So what do we do with this? And that rich data is what makes this tool really, really helpful, as opposed to a tick box patient experience tool. Other than that, I'm happy to take any questions.
Okay, any questions for Debbie on the patient experience report? Sally?
Debbie, I two things. I noticed, and I know this is the trend, that we get more complaints from the mental health side. And when you look into mental health, it's crisis resolution, home treatment, and community mental health team. That's my first question. Do you think that as we've gone through one team over the last year, there have been more complaints? Do you know how sometimes when you're going through a massive transformation, things can get worse before they get better? Do you think that's that, or do you think once we go, once we embed the one team, we should get less? And the second thing I wanted to ask you was, when I looked at, and this is going into the details, so I do apologise, Oakwood ward, when you look at the issue, there was a page 45, something about people being shouted at and requiring more information about planned treatment and the goals of the treatment, whether you sort of triangulate that with other information you've got around Oakwood ward, because it doesn't sound good, does it, shouting at patients?
No, it does not, and something that we wouldn't find acceptable. To answer your first question first, I think we are not seeing any increase at all in our mental health complaints, and we haven't done. That it's fairly static, and we also have to remember that actually less than 50% of our mental health complaints are upheld. So rather than taking the numbers of complaints received, for me, the focus needs to be on where we've got learning from them. But we've been very static. When I've looked at data before, Sally, it's quite interesting because we get less physical health complaints, but a slightly higher proportion of those partially and fully upheld. So when people do complain, it's with very valid and concerned reasons. I'm not saying that when mental health complain, it's not, they don't have a valid, that is how they're feeling, but we get a slightly less of those being partially and fully upheld. And sometimes, patient recovers and they actually would agree with that outcome. So no, in short, we haven't seen the changes that we're doing behind the scenes, if you like, are not impacting negatively on what we're seeing from a patient experience perspective, and that isn't being borne out in any of the feedback we're getting through I Want Great Care either.
And it's an important message to me of actually look at the upheld as much as I'm going through the numbers. No, thanks for that. And the Oakwood, and then sounds a bit alarming, doesn't it?
So we always triangulate. So we have an internal weekly meeting that triangulates patient experience and what's being raised, safeguarding, incidents, infection control, and anything else. So yes, we do absolutely look and triangulate.
And Oakwood's on your radar, is it, or is this just isolated?
This was an isolated, but yes, all wards are always on my radar.
Yeah, but particularly,
right. And sometimes there's perception involved with You Said We Did, so we just need to make sure we're being kind and compassionate all the time, and that patients aren't perceiving these sorts of things as well.
Right. Thank you.
Thank you. Sonia.
Debbie, first, great to see the patient experience overall summary so green, right, in terms of all the metrics. I just do want to acknowledge that. So, and they seem to be stretch targets was sort of my thinking. You guys, it seem to every month, I seem to get this, Julian, you clearly pressure, or whether it's pressure, or you all really determined to do exceptionally well. One query on the MPs, I'm seeing that on the increased, you've talked about increased pre-election levels. To my point of stretch targets, was last year lower because of some of what was going on, and therefore we think that maybe we've pushed ourselves a bit too hard on that? Are we kind of edging back to usual normal levels, or just any comments on that?
Yeah, so the target was what we in that one was what we saw last year. We saw quite a significant reduction post-election. Virtually all of our MPs changed, and we wrote out to them at the time, or Julian did, and we explained how they could make contact if there were concerns and things like that. But what we've seen in this quarter is no different to the numbers that we have seen in quarters pre-election. So it's returned to more of an even keel is what I would say.
Thanks, Julie. And the other one, just for my clarity, around the dominant negative themes, so in the main pack on page 23, I'm seeing the increasing of the dominant negative. Should I be reading that as a positive thing there? Like, is it from a scale of, or is it smaller numbers are better for the dominant negative themes? Like, is there an inverse?
Yeah. So I would always look at this over a period of time because they do fluctuate. But yes, so what we're basically saying with, I don't know, so say smooth transitions is at 21%. And last time it would have been at 8%. That's if my calculations are right. So yes, so
you do want those lower, but I guess I don't really know is that within their boundaries of what normal is? Do you know what I mean? Like that for me, I'm like, again, are they just the lowest scoring or the highest scoring or the worst scores effectively?
Yeah.
Right?
So the positive dominants are the top scoring it from a positive perspective. So 95% of everybody that fills out the questionnaire is saying that staff act with empathy and respect. At the other end of the scale, 11% of patients are saying that they didn't think their treatment was effective. So you obviously want to strive to have less than 11% of patients that fill out the questionnaire that say actually they're not sure that their treatment was effective.
Excellent. I appreciate that.
That's all right.
Thanks, Sonia. Rebecca.
Thank you. Hi, Debbie. Thanks for the report. I just was looking at the section where talks about the demographic data, and it mentions that obviously some of the patients completing the surveys aren't necessarily disclosing either gender or ethnicity data. And I was wondering, because I know when we struggle with collection of data, there are various reasons why people don't complete that. So I was wondering how that question is asked on the form and whether there's any explanation as to why we're asking for that, why it's useful. We'll always, I don't think we'll ever move away from a position where we make it optional, but is there anything we can do to kind of sort of encourage people to complete that data where it's not being completed?
We do explain to people. I think we purposefully put those questions at the end of the survey because we want to get the feedback, and we don't want people to spend, thinking I've only got 5 minutes, so I'm going to do all my demographic data and then not do any of the questions. So it's a real balance, Rebecca. But I'll certainly take it away and see if there's anything further we can add into the survey.
Yeah, maybe something that sort of takes it out of that normal, because I know, even myself, sometimes you'll just tick the easiest option of nothing. But if it's just got something that reinforces why we're asking that data, and even down to some wording around, X% of people normally complete this question, because from a psychological perspective, when you go into a hotel and they tell you that X people reuse their towel for the environment, there's all sorts of really subtle ways that you can try and encourage people to respond differently while still making it optional. So yeah, it was just, I know it's not just here, it's across the board that we struggle with collection of this type of data, but I just think there's going to be a continued gap where we can't really work out if we have a problem around completion rates, if we're not able to improve the response rate.
We do have something in there, but I'll certainly take it away, Rebecca, and talk to the team that lead on the administration of this.
Okay,
see if there's anything further we can do.
Yeah, thank you.
Gary, did you have a point on that?
Yeah, I just wanted to say that we do collect ethnicity data through other resources, which is, just complementary to what you're saying, Rebecca, not with sort of minimizing the point. So from complaints, from incidents, these are sources where we do have the ethnicity data, and we are making an effort to look at it even more in terms of waiting lists, sort of outcomes, etc. So at least where we have access to the data, we make an effort to look at it.
Thank you, Gary.
Debbie, as ever, the part of the report that I really enjoy the most is the "you said we did" part, because for me it demonstrates a learning organisation actually in action that is taking that feedback and learning from it and implementing change. When I was in Upton Hospital last week with the heart team, they demonstrated to me not only the "you said we did" piece, but they capture all of that and put it into a newsletter, which they provide to all of their patients so that they can join up that circle and demonstrate, not only did you say this, we took action, we listened, and we've changed as a direct result of it. You've got a huge amount of information in there of all of the actions that we've taken as an organisation. How is that generally fed back to the patients and to the people who are making the feedback to us in the first place?
So, Mark, I know that the reality is it's different in different services, and some services at the moment are doing it better than others. So if you go into some services, it's really clear, it's up on boards, except some do. So children's services, a bit like Heart Function, do newsletters and things. But I think we've got some way to go still with making sure that all services are ensuring that feedback gets to the people that have made it in the first place.
Yeah, it is so important. I know in my previous life working in customer feedback, to demonstrate the closure of that loop and the work that's being done as a direct response is a really powerful thing. So yeah, the newsletter that they gave me last week was really, really powerful. Thank you. If there's no other point, should we move on to Quack? And Sally, do you want to take us through the minutes which we've received?
Yes, I'm very happy to take any questions on the minutes, but perhaps I could pick up some highlights, and if I miss anything out, I'm sure Debbie will help me out here. We had following the NHS plan, clearly listening to patient voice and working with patients and carers is increasingly important. And we had a presentation on the Trust's co-production work. And that was very interesting, actually, in terms of the approach was very much start small and learn over time. It can be a controversial area, but people who are very much into it take very sort of ideological stances, but the stance taken by the QI team that are supporting this work was very much encouraging people to start small and learn over time. But clearly, and Julian made this point, co-production needs to be prioritised when undertaking service transformation. And overlapping with that work, we had an update on the carers strategy, and there's been a refreshed carers strategy, and what that demonstrated was actually year-on-year improvement. And we were assured as a subcommittee that the services across the Trust were engaged, but clearly they're very different and were engaging in different ways. no quality concerns were added to the quality concerns report, which was excellent. And I should mention the National Patient Safety Alert. I mentioned that at every board meeting where I feedback on the QAC, because obviously that's unusual for us in that it's one of the national patient safety alerts that we haven't been able to fulfill, sign off. But you will see there from the minutes that we're waiting for a regional solution. But I don't know, Debbie, if there's anything else I should add. I don't know if you wanted to say anything around the issue which other members of the board may have heard about around the supplier, you know, with the equipment, or whether you don't think that the board needs to be, they'll see it in the minutes of the QAC, obviously, or whether you want to say anything about that.
I'm happy to really quickly, Sally. We've had a nationally that our supplier in our 6 local authorities and the ICBs of equipment went into administration, and we've got a new supplier, and they are working to get up to speed with the service that was being provided previously. So we're working all very closely as providers with the new supplier. It's not a brand new supplier, it's a supplier who was supplying in parts of the country to ensure that our equipment that we supply to patients out in the community continues.
And it's been on the national news, hasn't it? So colleagues may have picked that up in newspaper, television, radio, etc. But I'm very happy to take any questions on the minutes.
Any questions on the minutes? Rebecca, is that your hand from previously, or did you have a question?
Yeah, sorry, that should have come down. No new questions.
Thank you. In which case, do you want to, the minimal changes to the terms of reference, but we need to agree those for you, Sally?
Yeah, there's a minor change to the terms of reference, clearly with a sort of restructuring at a senior management team level. We have deleted the lead clinical director role from the membership because that role no longer exists. We agreed to that, and we're asking the board to confirm that.
Could I just see a nod of heads? Anybody concerned? No, I think we take that as proof, Sally. Thank you.
Thank you.
Amanda, we've got now learning from death quote in the safe working. Do you want to take us through those two papers?
The first report, the Learning from Death report, is the report that went to our August QAC, and in line with the national requirements, it comes to board as well. The key point to note on this one was that we had one case where we identified a governance cause for concern, which is unusual for us. We haven't had one in the last 2 years. It related to a case directly related to pressure ulcer care and sepsis. And the patient safety team and the governance team for physical health have done some significant work to put improvements in place in that area. We had 2 cases where we identified poor care, but wasn't directly related to the death. And again, improvements have been in place, and it's detailed in the report. So I'm happy to take any additional questions people may have.
Any questions for Amanda on learning from deaths? I think we take that as read. Thank you, Amanda. And then we had the Guardians of Safe Working report.
And again, similar, this report has been to QAC as well, and again is required to come to board. Within it, there were 6 exception reports, one with which incurred a fine. And some of the recent changes we've put around the medical staff in team supporting the exception reporting and the requirements going forward. So again, I'm happy to take any questions.
Thank you. Amanda, can I just ask, that fine of £111, where is that money actually paid to?
So there is a Guardian of Safe Working pot. So Marla is our doctor, Guardian of Safe Working. She has a finance pot, which we pay that fine into, and then that can be used for our resident doctors. She can allocate the spending for them.
So I understand this correctly, it's held within the trust in effect?
Yes.
It is. Thank you. Just curiosity on my part. Any questions for Amanda on the working hours? No? Okay. Thank you very much. Going on to the intensive case management. Gary, you're going to take us through this for us?
Yes, of course. So, this has been developed as an action plan in our attempt to align with the NHS England guidance on intensive and assertive community mental health care that came around in 2024. And I would like to take you through the areas that we focused on this paper that has also gone to QAC. So the first area of focus was in identifying patients and resources that we can best use because this piece of work doesn't come with any additional funding. So we have identified approximately 100 cases where we feel they meet the specific criteria for assertive outreach, but we think that there might be more patients and we need to do some further work to triangulate with partners as to where these patients might be. Then the second area is looking into having very good links with public protection and forensic pathways in terms of preventing harm to others. So we regularly attend the multi-agency public protection arrangements and the multi-agency risk assessment conference meetings. We have clearly identified reps, and we have strong partnerships with probation services, the criminal justice panel, and forensic collaborations. Some of them were existing, some of them have been creating for this purpose. We've also looked at our DNA policy. This is what we do when a patient doesn't attend an appointment, and we have enhanced the standard work. The most important change is needing to have MDT input before a patient is discharged for not attending. We've also looked at the named worker and cover arrangements. So you would have heard of the Trustwide program of named worker. That's getting more and more embedded, and that allows patients to have a clear point of contact that is the main person responsible for their care plan, and how they can access this person and what happens if this person is on leave, who covers, etc. Then we also looked into the family involvement that we can enhance for this particular group of patients. So we had some groups with carers specific to localities, and they were attended by various people and senior leaders from the trust. So we invited people to offer feedback, and we also send a survey out. There is a thematic analysis that is coming to fruition soon. We will actually get to hear the results tomorrow. We also have a carer safety panel in place, so that's also linked with our suicide prevention work, and it gives the opportunity for carers that want to raise concerns to have access to us promptly. There is also a PSI training program that has been rolled out across all services, and that aims to sort of support skills development and risk training. And we've got standard work in place that we will be reviewing again later in the year. And then we're looking into our external and internal reporting. There's an expectation that we report to NHS England and other venues, so we try to avoid duplication. And we've got an assertive outreach team oversight group that meets regularly, and that's the meeting tomorrow, where we will be looking at the insights from the thematic analysis. And then in the paper, you can see that we have rated some areas of how we're performing. And if you like, I can comment on the one red, which is related to the depot prescribing. So this is the long-acting injections and trying to have a consistent approach across all our PCNs, you know, clear flow and free flow. And we have created this depot passports that facilitate that. This is an area that that needs work to happen with our local PCNs and GP in primary care colleagues. So it's rather complicated. That's why I guess it's still red. And I wonder if there are any questions for me, or if there are any other areas you would like me to elaborate on?
Gary, thanks ever so much for giving us that overview. And in fact, you had picked up on the one area that I was going to raise a question myself, which was the depot passport, because those are so useful in terms of allowing patients to go on community treatment orders, which is far less restrictive than holding them under a section. It feels in reading the report as if you're struggling to get traction and acceptance from the PCNs to adopt that. How confident are you that you will achieve that and get it back on track?
Well, I'm reasonably confident, I guess. I think it's important to look at what makes it hard for our GP colleagues to engage with that. It's completely optional. It attracts a minimal additional payment for them, but primary care has been overwhelmed by work, all of us, I guess. So it's trying to see what can we do to support them do that work for us. So through having closer relationships, through being more prompt in responding to any queries that might have any problems, because I think there's a level of worry that if they take over the prescribing, if there are any problems, will we respond in a timely manner? And there are initiatives happening at the moment, like the advice and guidance initiative for GPs that we hope that we can use to our advantage. So this will be yet another pathway that they can access us, and we can respond if they have any questions. Yes. So I hope it will be resolved, but there are many PCNs, we work across 6 local authorities, different pressures and different relationships.
Thank you. Sonia.
Yeah, Mark, I think mine's extending from that as well. So I'm just intrigued, when I read the red, is that because it's a delay and you think it won't be completed by the March 26th, or was it more it's unlikely to be achievable at all? So I didn't really understand your RAG, right? So if I can understand what's the red versus...
So I think it's because it's more complex work and it takes longer. And how successful we are across all the areas that we want to be successful remains to be seen.
Thank you.
Sally.
Gary, I know I had opportunity to ask you questions at the Quality Assurance Committee, but this has just occurred to me since I've read the board papers today, and particularly this part 2 that I was looking at the work that Oxley's done. And it occurred to me then, when you look at what they've done around their forensic patients, they looked at unconscious bias. And I was thinking around, when you get the criteria looking at these patients that you categorize in this way, and I thought the same actually around the criminal justice panel, whether the unconscious bias might be a consideration. And it was only after reading the work that Oxley's had done with their forensic patients that this sort of question came up for me.
Yes, I'm not sure I understand your question, Sally, fully, but my initial thoughts would be that it's always worth considering unconscious bias, and there are some specific groups of patients, particularly those that might be having a sort of coma, sort of alcohol and drug substance misuse issues, that we need to keep ourselves double check that there isn't any bias of excluding people, and then ethnicity data as well. Are there some groups misrepresented? So I think that's a good point for us to bear in mind.
Looking at the demography of the characteristics of the people that we categorize in this way. As I say, it didn't occur to me until I looked at this sort of the part 2 and thought that that this could be an issue for these types of initiatives.
Yes, it could be, and I'll bring it to the oversight group tomorrow for further discussion and consideration, but thank you for raising it.
No, thank you.
Thanks, Sally. Thanks, Gary, for that update. It's really useful. Moving on to winter planning. Debbie, do you want to talk to your paper?
Yes, thanks. Thanks, Mark. Doing this on behalf of Teresa today. But as part of this year's winter planning process, NHSE have asked us for assurance that boards have oversight of the plan and key considerations have been met, and there's an ask that the chair and the chief exec sign off this plan by the end of September. The only part of the plan that has not been answered as a yes is around the regional testing, which I believe took place yesterday, and we've got some local testing of the plans in October, beginning of October. Papers include checklists that sit behind this statement. There's one for flu. There's two areas in that where it's marked at the moment as no assurance. The reason it's no assurance is because we don't have maternity services and we wouldn't be providing, but there's not an ability to say it's not applicable to us. So I have changed that for Julie to say it's assurance because we are green. We're never going to be providing that. So, and then there's one amber on there that is now completed, which was about ensuring that patients with an over 28-day stay with us and those being discharged to care homes are offered the flu vaccination before they are discharged or during their stay if they're in with us for a long time. So the flu element is also fully compliant. Other than that, I'm happy to take any questions.
Thanks, Debbie. Debbie, you mentioned that yesterday there was the regional test. Do you have any even anecdotal feedback as to how that exercise, or is that far too early to get a view?
I mean, no, it will be getting people together to work. I mean, we do it every year. I guess what I would say is there's nothing in here that we don't do every single year as part of our winter planning processes. It's just that this year it's been asked for board sign off. So I wouldn't envisage it going any differently than it normally does, Mark, in terms of being a tabletop exercise that is just testing that there is resilience and people respond as they should do if we end up with, issues with too many people needing our services, basically, is usually what it is, or a lot of staff sickness or things like that. So there's nothing that I would say is out of the ordinary from our every year practice within this plan.
Great, thank you. Any questions for Debbie on that paper? No, we can take us round. Thanks ever so much. Moving on to the executive report, Julian.
Morning, everybody. Yeah, there's a flurry of activity from NHS England between sort of mid-July and mid-August, and you can see in the executive report a number of those activities are sort of captured. So very happy to take questions. Should say, just hot off the press, the National League tables were published today. They're on NHS England website. Out of 68 community mental health trusts, we were ranked in segment 1 and 3rd overall. So they're work in progress, we should say, but if you look on the website, we're there 3rd overall nationally, which is obviously pleasing to see. With a slight word of caution, I think there's some really good indicators there, and there's probably some that are kind of work in progress, if I'm honest with you, but really helpful for us in terms of, it does reflect things like the staff survey and some of the work we've done in reducing waiting times, in particular, as an example, which have been really helpful. And so it's good, really good news for the organisation. I shall pause there and just allow any time for any questions in terms of any of those updates that have been provided, particularly the NHS England stuff that can hopefully self-explanatory.
Any questions for Julian? Just a couple of things from myself. First of all, the provider capability piece, Julian, is there any input from us as a board that we will need to undertake for that, or is this something that the executive will be submitting without our active involvement?
No, we'll be doing the grunt work and then presenting it to the board. So effectively pulling together the kind of evidence where there might be some gaps, and then presenting that prior to sign off, so there's an opportunity for board members to see that. That's the plan. So actively working on that at the moment, sort of marshalling the information. Some of it is familiar territory, Mark. So we used to do it. It's quite similar to what we used to have under the old regime of Monitor. So quite similar around that. Some of the stuff also overlaps with the CQC kind of well-led stuff. So we've got quite a lot of stuff that we can sort of marshal. For us, given what I've just talked about, where we're at as an organisation, it might just be about sort of querying where we might have a gap and what we want to do, rather than trying to find, all the supporting information where it's pretty, I think it would be pretty obvious for board members that where we're doing sort of well. But no, you'll be involved, but appropriately, I hope.
Thank you. And the only other thing I was going to say is it would be really remiss of me not to commend you and the rest of the executive team in terms of today's official announcement, in terms of those league tables and the positioning of the trust. That really is a significant achievement. So congratulations to all of the executive and the leadership team in terms of that achievement. It really is quite a significant piece for you.
Thanks, Mark. Much appreciated.
Thank you. Performance. Moving on, Paul, do you want to take us through the finance and performance report?
Yep, happy to. So the finance report is to the end of month 4. Just pull through some of the highlights for the board. I think generally, I would say we're in a good, solid position. We're continuing the good start to the year that we've made. If you look at the dashboard on the second page of the report, you'll see that against most of our financial indicators, we are performing to or better than plan. The one that sticks out, and the only one that sticks out as red, is against the agency reduction target, where we're 5% off where we are expected to be from NHSE, but the reality in terms of fiscal value is probably less than 100,000 there, so it's not hugely material in terms of our financial position. We closed the month with a £1 million surplus, which is in line with our plan, and we're continuing to forecast that we'll deliver the plan for the financial year. Our workforce numbers have remained broadly flat, I think probably through a combination of some areas where it's difficult to recruit and other areas been on top of their recruitment plans in order to manage within their financial control totals. The net impact of that is that we're 1.3 million underspent year to date on our pay position. Temporary staffing, which obviously has got a lot of national focus. July, we would normally expect to see a slight uptake in expenditure, simply because we're heading into holiday season and we've got more temporary staffing cover requirements. But we're still seeing, despite a small increase, costs down significantly on where they were last year. So expenditure is about 24% less July this year compared to July last year. Year to date, agency, we're 25% down on expenditure compared to year to date last year, which is a reduction in costs of about 600,000. And bank, we're 21% down year to date in terms of our expenditure this year compared to the same period last year, which is a reduction of about 1.4%. So we're exceeding that national target reduction in bank spend. Target's 10%, we're at 21%, which is positive. And I know Debbie is leading the group, which is continuing to main focus on our temporary staffing spend. So really good to see. On the non-pay side, we did have some pressure earlier in the year because of our PQ placement costs. Those placement numbers have reduced and are below plan now, which is good. What we are seeing is a slight uptick in our specialist placements, which we just need to keep an eye on because that's kind of replacing the PQ pressure. Savings, we're on track year to date with the savings programme. Where we have got some schemes that are behind plan, like opt tax, we're speaking to system partners to try and unblock some of that, and we're continuing to work with corporate areas to deliver corporate savings target, which hopefully will benefit us this year and into next financial year as well. What it does mean is we've had to release slightly more balance sheet saving than we expected at this point in the year. But like I say, we did have a quite significant level of balance sheet that we were expecting to release, and we did agree with the board that we would do this year. From a capital perspective, we'd planned to spend 3 million to this point in the year. We've spent 1. Couple of key variances just to note. 800 of that 2 million variance is down to Jubilee ward move, which will happen as planned. It's just a phasing difference in terms of when the plan was assumed to be spent. And we've got 1.2 million of leases that we expected to sign by this point in the year. Nicholson's we've now signed, so that will be rectified in the next month's report. And then there's an amount related to a building called Chalvey, which we're moving into in Slough, with some GPs, which we'd expected to be in by now. Probably isn't going to happen until Q4, so still expected to happen, but it'll be slightly different to when we assumed in plan. In terms of cash, still looking healthy, 53 million, 4 million higher than expected. We've now resolved the alignment of cash payments to this year's contracts with our ICBs, and the report that says we've got delays in payments to PS, we've made partial payments on some of those. So cash is closer to plan, and will be reported to the next board meeting. Happy to take any questions there, Mark.
Any questions for Paul and the finance side? I think it's encouraging, Paul, that you've got such a steady ship. I know it's still very early in the financial year, but all the indicators there are running smoothly. So again, thank you to you and the team in terms of managing it as effectively as you are. Thank you. In which case, shall we move on to the performance report? And Gary, do you want to take us through the highlights of this?
Yes, thank you. So, Mark, I was thinking of taking us through the whole of the breakthrough objectives and then a couple of the driver and trackers, if that's all right. Yeah. Cool. So our breakthrough objectives are, the first one is restrictive intervention. So this is the rapid tranquilization. And we're pleased to see that there is a steady dropping of the numbers. We still have 32 we had in July. Those were linked to 10 patients, and one patient had 23 incidents of rapid trank. So the next one is adult average length of stay in bed days, and it's 48.85, which is higher than the target of 42. We have identified the highest contributing wards, and we've also noticed that Bluebell, that is the ward that has completed its fishbone analysis, has been, below the target for a study of 4 months, and we're looking to learn from Bluebell and take on the actions to the other wards as well. The older adult mental health average length of stay was 81.86 days. So that's very close to the 80 days. And I understand that in August that was green. So it went to further improve. Physical health in our community inpatient average length of stay is 22.3, so not far from the 21, but still above it. And then one that I would like to draw your attention on is the physical assault on staff, where we are at 70 against a target of 36. And we have noticed that the numbers have been increasing over the last 2 years, and that's a big worry for us. We have already started an A3 where we'll be process mapping and looking at the root cause analysis and what countermeasures we can put in place. And we've got an improvement event coming up in September, but that's an area that definitely needs attention. Is there a question for me now, or shall I continue? Continue, okay. So in terms of our driver metrics, I want great care. Our experience score is 94.6 against the target of 95%. So we're really getting close, and we hope we will meet the target. And our compliance rate is reported here as 6.7%, but it's actually, like Debbie mentioned earlier in the meeting, 8.8%. And the discrepancy in the numbers is based on including the paper copies that arrive a little bit later. So they're not included in the 6.7%, but the actual number is 8.8, so not far from the 10%. We will make some changes there to sort of adjust that going forward. The rest of the driver metrics are green, so we're celebrating those. And then our tracker metrics, we're good with our, we're above the target of 3.5 with the sickness rate. We're at 4.4. And we've got the bed days occupied by patients that are discharge ready for our community services are higher, and the same for the clinically ready for discharge for the mental health wards is again higher than the target. The health visiting, which is a new birth visit within 14 days, is 87.3 with a target of 90% per month. We're keeping an eye on our talking therapies in terms of reliable improvement, both for free Bob and reliable recovery. They're very close to target, but not quite there. So we're keeping an eye on that. And you can see that we're not meeting the access to perinatal service target. That's across Bob is 595, where the access should be 611. I think it's 120 for us in BH15. Yes, so we're also reviewing the self-harm in the mental health inpatient wards, where we're above the target of 61, we're on 108. So happy to take any questions if there are any.
Thanks, Gary. Rebecca.
Thanks, Gary. It looks like a good picture overall. I just had a question on the first one. So where the restrictive interventions says that that there is no target, and the teams are reviewing countermeasures and a target. Just when is the target likely to be set?
I'm not sure. I'm not sure is the answer to that. There have been some changes with the restrictive interventions, and we and you might have noticed that historically that the numbers might have changed. We're looking like the national norm is we're looking at the intramuscular. Sorry, I was talking about rapid track. So yes, I don't know about the restrictive interventions target.
We'll come back. We'll get someone to come back on that one, Mark, if that's all right. Teresa's around.
Yeah, I was going to say if we could just take an action for that to be picked up, and we'll come back, Rebecca, but hopefully with an answer for that.
Thank you.
Sally.
Gary, I'm very aware that trying to reduce self-harm and assaults on staff are very complex, and we've got multiple initiatives going on. But when I was reading through the patient experience report, I noticed one of the feedback from the mental health prospect part was more activities, and I wondered whether you and I'm very aware also that Debbie said that can be perceptions, but I wondered if we actually had we looked at activities on the wards, or whether we had an overview. Did we at a management level of what sort of quality of activities there were on the ward? And I wouldn't insult you by saying have you considered activities, because I know but whether, given that I'd seen that response, that feedback, whether there was a sort of overview of activities as one contribution to reducing self-harm and physical assaults on staff.
Yeah, so we do keep an eye on the activities in general, and in particular what's happening at the weekends, which is the staffing is different, and this is an area that we hope to be enhancing even further. We're also looking at the psychological input for the inpatients, and the support that we have from psychology colleagues, and also about transparency of what happens during busy times, when I'm thinking of co-production and participation of patients in the setting up of the day-to-day arrangements and the day-to-day plan. so that people are not excluded and
Yes.
they know at all times what's happening. Yeah, so activities.
So we've got some sort of overview. The management team would have an overview of the different level of activities and what's on.
Yes,
Thank
we
you.
have been going back to look at you know, to do a bit of a deep dive at the people that do assault, and you know what was happening at that point in time, what was happening around them, what was happening in terms of their you know, known risk. Was that communicated? Was that managed? So reviewing the way that we manage risk and the way we communicate what works for some people.
Right. Thank you very much.
Sally, I sense that Debbie wants to give another perspective on that.
I just wanted to help answer that question. So all of our mental health wards have activity coordinators that work from 5 or afternoon through till late evening, because we recognised when we did some work quite a long time ago that that was where there was most challenge in terms of assaults, self-harm, etc. So all of the wards have their own. Now, we don't have a blanket, this is the activities you want to be doing, because the activities that the Bluebell, which is all female, might want versus the activities that are on Daisy Ward or male might want are very, very different. But this is all part of the culture of care work that's being looked at as well. So I just wanted to join those dots up really. So if you walked onto the ward, you'll see that they have displayed, Julian and I were there on Friday, and you can see they have displayed what activities they are doing, and it's something that they are proactively looking at and working on as part of culture of care alongside the activity coordinator role.
Right, thank you.
Thanks for that, Debbie. Any other points or questions for Gary on the performance report? Rebecca.
I just had a question just to help me understand the data on the clinically ready for discharge bed days, so the target of 250 bed days. Looking at the red and green chart with the data from August 24, it seems that over that period it's sort of crept up each month. So October 24 within target, and then it's gone up and up and up through to January 24, and then we've ticked into red from February. Just whether there's something that's causing that increase in number of bed days.
My guess, Rebecca, is that it's a combination of factors. So we have seen the complexity of our patients increasing. We have seen, pressures on services increasing. The staffing pressures, etc. So we're doing a lot of work with through Red to Green project to identify the reasons that people might be staying in hospital longer, and identified how we can address the bottlenecks. We have seen that there is sort of their pharmacological, non-pharmacological, and process reasons that increase the length of stay. And we're working very closely with our local authority partners. We have regular meetings. We have coordinators that sort of facilitate people's discharge. We identify those that are clinically ready for discharge and try to address what might be stopping them. But from the work that we have done so far, we feel that there are at least 2 or 3 reasons why we have these bottlenecks.
Okay, thank you.
Thank you.
Thank you. Otherwise, thank you, Gary, for taking us through. It was useful as well going in a little bit more detail this time through those various metrics. So thank you for that. I'm hoping that Sonia is back on. I know she was having problems with her system.
I am, Mark. Thank you.
Super.
It's always the way when you're about to speak, things go haywire. So a little bit of panic in the background. Just from my, I just want to say there was a comment I think it was you, Mark, or someone just made about a steady ship. And from my side, to have a steady ship is not easy. When you're on such a big, if you're on a huge cruise line boat, to actually keep it straight is phenomenal. So for me, it's, you know, my big observation is a significant effort, not just to deliver the financial results and the performance that Gary spoke, just mentioned now. That takes a lot of significant effort. And I want to acknowledge that. And I think the results are also showing in terms of where you've been rated. So that for me, it's not just, Paul, you used the word, it was a good start and you're performing to plan. I think it's an impressive, great start and aligned with a great place to give care and get care. So I think they were some of my observations in the FIP meeting. It is now 4 months, and 4 months, Paul, to be 9 out of 10 metrics in green is really great, and you've got plans to get them fully all on track. So I want to again, Julian, acknowledge you and the full team, the operations team that delivered that, not just Paul and the finance team that measure the results. And Gary, I think if you can pass that, I think it is very complex in terms of what we look at the performance. The amount of metrics that you have to look at is, for me, sometimes overwhelming how many you're looking at and which ones are the true north. You really are not that far off, where, there's a lot of red that we look at. But again, similar to my early point, there's some real stretch targets that you're putting on yourselves to be that outstanding, great place to give care and get care. So they were probably some of my feedback, initial comments that I wanted to give the team, was more my gratitude and appreciation for the time and effort that goes into making these cuts, but more importantly, the time and effort and care, diligence into delivering the performance that's been delivered. Then if any of the other trustees on the FIP would like to make any other comments.
And indeed, are there any questions from anyone for Sonia regarding FIP? Obviously had access to the minutes. Okay. Otherwise, thanks, Sonia. Much appreciated. Moving on to strategy. Alex, there's a number of different areas now coming forward for you. Do you want to take us through the different papers?
Thank you, Mark. So we've got the Workforce Race Equality Standard and the Workforce Disability Equality Standard. These are annual national benchmarking of set indicators and our analysis and initiatives to address the inequity that they show. I think it's encouraging to see progress and improvement in all of the indicators across the RES and WDES, with a particular area of focus remaining for us in workforce race equality around abuse and discrimination from members of the public. But the progression is really important because we've been working hard actually to focus our anti-racism work and other initiatives, culture of care, particularly at Prospect Park. And I think the insights we have through the work that Stephen Strang, Ash and the team have been doing this year, I think hopefully the board will see a different quality of analysis that tries to draw out a better understanding of all of the drivers and root causes of our positions here with our workforce. What this says to me is for workforce race equality, Prospect Park is a really and continues to be a really important focus for us. But we also need to understand the wider inequities across the rest of the workforce in both race and disability. So I think I'm going to leave Jane now to take us through a quick summary of the insights. We have Ash and Stephen here as well, and then a discussion and any questions, comments or clarification. Thank you.
Thank you.
Yeah, thank you. Given the time, I'm going to gallop through these quite quickly because I'm conscious that you're overrunning. But just to say that this deep dive is in response to the request from the board last year, where we felt that we'd reported the RES and the WDES, but really hadn't got under the surface. And Stephen particularly has done an enormous amount of work to try and understand not just what the report has been telling us, but some of the intersectionality as well. And I'm hoping that that's coming through in the presentation. Just for those of you who are aware, the workforce race equality, what we call RES, and the workforce disability equality surveys are something that everyone in the NHS has to publish. we have to analyse and publish, and they date back to 2016 and 2019 respectively. So if we go to the next slide, please. This is an overall snapshot of our performance, and I'm conscious that doesn't necessarily come across well in the slides when you see them, but they do in the presentation, which is why I wanted to show the presentation. Stephen, if we could move on to the next animation, that really shows you the areas that we have done better in. So we've done better in 17 out of our 22 indicators. We've seen positive movement, some obviously bigger than others. And then if we look at the ones where we've declined, we have 3 that have declined. So you can see the 3 that have declined there, and then we have 2 which have remained neutral. If we move to the next slide, please. The origins of the RES came from a report that Roger Klein did. Roger Klein does a lot of research into the NHS and the health inequality, the inequalities, particularly for the workforce in the NHS. He looked predominantly at the AFC workforce. What we have tried to do with some of our work here is expand that to also look at our medical workforce as well. What Roger Klein, I think, didn't look at was the fact that actually some of our, some of the information that we have here, reflects not just diversity in general, but also about age as well in the organisation. So nationally, the diversity of people in the population, their age is around 31.6 years, whereas white people it's 42.7, and we have the same diversity. So our average workforce age is around 43.9, and what we find is that as we deep dive into this, we will see that in more of our senior roles, more people are white. That changes significantly as soon as you put medical staff in place. The ethnicity of our workforce also changes depending on which professions you look at, and we do have some wide-ranging differences. So, for example, again, going back to medics, almost 45% of medics are ethnic diverse, whereas only 12% of clinical psychologists are. So we do have to think about that workforce mix and the age mix when we look at the RES information that we have here. If we go to the next slide, please. Alex referred to Prospect Park, and Prospect Park does have an impact on our data here significantly. And Prospect Park is only 7.6% of our workforce. Let's just put that into context. But 23% of our disciplinaries occur at Prospect Park. 71% of patient on staff incidents are at Prospect Park, and 46% of staff on staff incidents are at Prospect Park. We have to layer over that the Prospect Park have a very diverse mix. 71.5% of the staff there are ethnic diverse versus 29.6% trust-wide. So PPH heavily shapes our RES outcomes. So it's again recognising that. And inequities here are going to reflect therefore in our overall RES and WDES reports. We do have to be aware of that. Now, this slide is a little bit difficult for me to explain, but I'm hoping I've got the right information here. But I'm sure someone will correct me if not. What we're trying to show you here is that people. We have 2 types of candidates who apply for us. Candidates who need a work permit, and candidates who don't need a work permit. And we have certain roles where we can open those up to people with a work permit, and some where they don't qualify for a work permit. And what we have found is that vacancies where we can consider candidates who need a work permit, we have what we call application clustering. We have a lot more ethnically diverse candidates who therefore apply for those roles. That again skews some of our data, because therefore we have a number of people. We have a higher number of people applying You know, sometimes we can have, you know, up to 200 people applying for some of those roles, and not, you know, we're not going to be able to offer 200 people a job with us when we've got one vacancy. And so it looks like we're actually rejecting a huge number of ethnically diverse people because we are, but only because of that, you know, that's application clustering, which skews some of our data. However, even if when we look at, you know, right to work roles where, you know, we can take, you know, where for non-right, right to work vacancies, we still see that phenomenon of application clustering. And what we are seeing is that our white candidates are often applying for roles with a smaller number of candidates, a smaller number of competitors. So again, there's information that we need to have a look at there. Within the presentation, Stephen's giving you a sort of example of how ethnically diverse candidates applying for one role disproportionately will affect our whole figures. I just really wanted to highlight that. If we go to the next slide, gender also has a huge impact on our recruitment outcomes. So actually, if you're an ethnically diverse female, you are more likely to be appointed into a role than a white male. And we do see that ethnically diverse males are our least likely to be successful at interview. And again, in disability, if you're a disabled female, you are the most likely to be appointed to a role in this organisation. However, if you're a disabled male, you are the least likely to be appointed. So while there are gender issues, they're overlaid as well on some of those ethnicity issues. What does that mean, Mia? When we look at equal opportunities for career, if we go to the next slide, Stephen, back again, to the equal opportunities for career progression, because this is really important, you know, are we seeing our ethnically diverse staff being able to apply and be successful in roles? And what we are seeing is that, yes, they are being successful. The promotion rates for ethnically diverse ASC staff compared to white staff is actually, you know, more than double, or almost double. And the promotion rates for our disabled compared to our non-disabled staff are again higher. But what we're also seeing is that there's an appetite for progression. So our ethnically diverse staff are applying, you know, in large numbers for opportunities in the organisation. So over half of our ethnically diverse staff have applied for a role with us in the last 12 months, as opposed to only 20% of our white staff. You know, nevertheless, you know, we've got to continue to examine any perceptions that people have around ability to progress in the organisation, and we keep, you know, looking at actual promotion rates to ensure that, you know, we are seeing that there is no disproportionate effect on any group when it comes to applying and being successful for roles. But there does seem to be a difference, you know, between people's perception of what's happening and what they report in staff survey, for example, and what is really happening on the ground. So some of our challenges is understanding the full contributors to inequity, you know, age, you know, the site, you know, being at PPH, professions, that sometimes the outcomes and staff progressions don't always align. Prospect Park is a dominant outlier, and we are talking to Prospect Park, and my SMT are going to Prospect Park to look at developing a people plan here, you know, particularly around some of the employee experience piece. And we've also got a case working review where we will take a real look at, you know, the disproportionate impacts of casework on some of our ethnically diverse staff. And then there are some national factors which are sometimes outside of our control, but, you know, we are using things like our apprenticeships to try and improve and increase the diversity of certain professions, particularly areas like the AHP professions. And then recognising, as I say, some of the distorting effects of application rates on some of our data is a challenge. If we go to the next slide. So our actions going forward, is, we're going to continue to look at strengthening the data quality in our reporting. We have escalated some feedback to NHS England about how, we could misunderstand some of the data that's coming through, not just from our own report, but other people's reports as well, other trust reports. And a little bit about developing a communication strategy now to share our progress, really what's happening, because we've got some really good, progress taking place. And I do think some of our focus on anti-racism in the last couple of years is really beginning to help us to shape and change some of the things that were worrying us a couple of years back, and then continue to focus on our challenges. And we've got a very clear plan about what we want to do, and we will continue with our plan, particularly around aggression, abuse, for example. And I know Ash has done some huge amount of work in that space, and as I say, focusing on that targeted people plan for Prospect Park Hospital. I'm sorry, that's been a really fast gallop. Open to any questions, and obviously you have got the full RES report and the full WDES report if you want to have a look at anything in more detail. That was a fast trot through some of what I thought were the key highlights for board.
Thank you, Jane, and thank you also for the 2 detailed reports, which again are really useful in terms of giving us a comprehensive view. Aileen, question from yourself.
Incredible amount of data that is really insightful. So thank you so much for that. The bit that kind of really struck me though was the difference between the number of applications from ethnically diverse staff versus the white staff. So 51.6 versus 20%. Do we know why that is so different?
No, Aileen, that's the first time we've really deep dived into this and seen that difference, thanks to some of the work, the work that Stephen has done.
Yeah.
So no, we don't know. Now, I don't know whether that is reflective of the fact that I think diverse staff are probably clustered again because of their age in some of the lower graded roles. So there may be more opportunities. Don't know. That's one of the things we've got to have a look at. Absolutely.
Because obviously, ideally, we want everything to be equitable. Yeah. So that seems very, very different. Okay, right then. Thank you.
Sonia.
Yeah, Jane and Stephen, what a great deck. So really comprehensively created. So thank you. And to Aileen's point, great to see the data. 3 reflections from me, Mark. One, what positive trends? I wanted to acknowledge the actions, Jane, that are being taken are clearly taking effect, which is always good to see. I think that proactive proposals that you're proposing in the pack, for example, having a PPH people plan is fantastic to hear. And thirdly, for me, the poignant point that you're making around perception versus reality, Jane, and how do you communicate to people? Because people believe perception is their reality, right? Even if the facts aren't so. So that was on my mind most, really.
It's a really good point, Sonia, but actually it is some people's reality. So actually, if you are an ethnic diverse member of staff and you're applying for a role where there is much greater competition and you get rejected, and then you apply for another and you get rejected, that is their reality. So they think that there's less opportunity to progress, even though other ethnic diverse colleagues are progressing. So that's what we've got to balance very carefully in the organisation, because if half of our Black and ethnic diverse staff are applying for the roles, not all of them are going to get them.
Yeah, which is hard, right?
Yeah,
the other one, Jane, I noticed was the more likelihood of females to get role. I know from my corporate, research in the corporate world is that women tend to apply for roles that they're more likely assured to get. Right, and I didn't see that coming into this, so it was just something I was mindful of, that okay, it might be perceived that's a bias towards women. Or is there something in that, Jane, as well as that, known research that exists? So I just wanted to highlight that as a consideration.
And again, we don't know at the moment. You may be right, Sonia. That's a really good hypothesis, and that women are only applying when they think they've been tapped on the shoulder for a role. Yeah, or that they've got a really strong opportunity to get the role. And, we do know men, will apply for more roles, even though they may not be qualified for them, which is why they may have a slightly lower success rate. But this is where we're saying we've got to deep dive into some of this data now that we've seen it for the first time.
And the mix of our workforce is highly relevant, isn't it? It's majority
Yes, it is.
female.
Female.
Yeah.
But fantastic, Stephen and Jane. It's so great to see how data led you are. Often in people organizations, they aren't so data driven. So again, that's my acknowledgement of that, right? It's fantastic you're using data to make people judgments as well.
Yeah, and we have to, we have to thank the board, because the board asked us to go and deep dive into this, which is why we've done it as well.
Thanks, Sonia. Sally.
Jane, you may have already done this, or perhaps you'll tell me it's a stupid question. Do you think there'd be any mileage in benchmarking Prospect Park against other similar mental health inpatient units? Because it has particular characteristics, and we're sort of comparing with the rest of the trust, whether we get a better sense of what the issues are, or what the progress is in terms of doing that, if we were to benchmark them. And my second question was, when I went through all the data, it did seem strange to me that, and I may have misunderstood this, our healthcare assistants comprise 8% of the workforce, but make up 31% of the disciplinaries. Is that right?
Yeah, and again, I think that will be one of the things that we need to have a look at through our case working review. Some of the hypotheses that have been put forward by leadership team at Prospect Park is that those staff are more more in contact on a daily basis with our our patients, who are and more therefore vulnerable and exposed to potential claims against them. Just because somebody goes through casework, it doesn't mean to say that there is they have done something wrong. In some cases, they have.
No.
Yeah. So they can be accused, and there's no question to answer. Sometimes we perhaps not. We have hypothesized about whether we're giving them enough training. We do offer a healthcare certificate, which explains around what's appropriate, what's not appropriate, and etc. as a healthcare support worker. Does that go in early enough? Are we giving enough information? So all of those things we will take a look at as part of our casework review, because we've got to try and do something to understand why that's happening, and protect our staff if there are things that we can do to protect them from being accused, if they're being accused falsely at times.
Absolutely, and it must impact on morale.
Well, strangely enough, as you know from other presentations, Prospect Park now has one of the highest retention rates in the organisation. So they are doing a lot of things right. And we've actually found that the turnover rate for those staff, for example, who are being assaulted, is actually lower than those who have who have less assaults. Now, again, we don't know why that is. That's something that has been, come through from the work that Mike Crosati has been doing. We don't know whether that means that people are more resilient, or whether that perhaps that they've lost their confidence to apply for roles, or maybe they're trapped in roles and they can't go anywhere else. We don't know. So there's a lot of complexity and lots, as you can hear, lots of questions. And sorry, Sally, I haven't answered your first question. What was your first question?
The benchmarking. Whether we get a better sense.
We haven't benchmarked, but we could take that away and have a conversation about whether we think that's worth doing, because I'm sure others might be interested in that. For example, other trusts with a similar facility.
Thank you.
Thanks.
I think the insights and possible conclusions are really helpful and interesting. I've just we've got to be careful not to say that it's the environment of the mental health inpatient units that's causing abuse, harassment and discrimination to the majority of Black and ethnically diverse staff at that site. There is something in the work that's happening there, but it just leads us to really, really carefully unpack what are the drivers, and particularly getting the perspectives of staff around this. So I think that one of the key indicators we've got to look at alongside the environmental issues is the harassment and abuse statistic that is going the wrong way and is most likely focused at Prospect Park, because they are ethnically diverse staff working in that area. So just holding that position, it's brilliant. We've got the insights, but we've got to be really careful not to knock things over or push aside. So it just leads us to focus to Prospect Park and our support and change there.
Yeah, but to add to what Alex is saying, you know, we do know that our staff in the community, for example, are going out and they're facing outright abuse because of their ethnicity in a way that I wouldn't have expected in this day and age, but blatantly racist behaviours. So what we can't do is minimise the experience elsewhere just because more of it's happening at Prospect Park.
I think Sally's point about a benchmark to mental health inpatient use would be really helpful to see if there are other environmental impacts that others are seeing and are having similar or getting on top of that experience for our staff there.
Yes, it's good call. Thank you, Sally.
Yeah.
Well, thank you all for the work that you've been doing. And sometimes when you sit through board meetings, and I joined the EDI steering group a few weeks ago, you can receive these reports and hear that we're making good progress, but it can sometimes feel a little bit academic and theoretical. And for me, there was a really grounding moment 2 weeks ago when I went on a visit to Prospect Park with Julian and Debbie. And we went on a tour of a number of different wards, and I asked the unfair question that I ask of most people at the moment, which is, if you were in my position as interim chair just for a few weeks or a few months, what are the things that you would really give your focus and attention to make a difference to the work that you're doing with your team on these wards? And the ward manager turned round to me and said, please keep the momentum up on all of your EDI initiatives. And she went on to explain the diversity of her team and the difference that all of these initiatives that we hear about, both in the board and EDI updates, as exercises, making a real and tangible difference to the lives and the work that those people are doing. And so there was a really wonderful grounding moment for me that day in terms of these things that Ash and Stephen and Jane are doing on a daily basis are having real cut through to the front line. And so I just wanted to say a genuine and sincere thank you for that work, because it is really making a difference.
Thank you, Mark. Because it is, at the end of the day, we do this because we want to positively impact on people. That's what we're all trying to do here. And this data, as you say, is helping us to uncover some of those questions and that have been raised today. So it's been really helpful.
Thank you, Rebecca.
Yeah, I just wanted to echo those comments, and I think particularly, the importance of keeping going, keep plugging away at the real whys and wherefores under that that underlie that data, and particularly in the current climate, because we're seeing a lot of EDI teams disbanded elsewhere, particularly in the private sector, and all the stuff that's coming from the state. So I think for the trust to keep this at board level and all the way through is really important. So yeah, thank you.
Yeah, thank you. Well, thank you, everyone. Thank you for your ongoing support. We appreciate it.
Thank you very much. Moving on to corporate governance, Rajiv, do you want to bring out the highlights of the audit committee?
Yeah, happy to take any questions. I would say this, the last audit committee was the one where we wrapped up the final comments with the auditors on this year's financial audit. And they were very complimentary of the collaboration with Paul and his finance team. So, I once again want to thank the hard work of those guys too.
Any questions for Rajiv? No. I think you've got off lightly there, Rajiv. Thank you all. Use of the trust seal, Paul.
Yeah, relatively straightforward. So seal's been attached to 2 documents this month. One is the revised lease on Nicholson's house in Maidenhead. We've reduced our occupation in there based on need for clinical occupancy and our ongoing work to improve utilisation of the estate. The second time the seal was attached was around the PFI survey deed documents, which we've been negotiating with our PFI provider and ISS over a number of months. So really good to get those signed off.
Thank you. Moving on, Council of Governors update. Outside of the formal council meetings, I had a meeting with Brian Wilson, the lead governor, last week. We discussed a number of different issues, including some feedback that I've personally received from other trusts, where concern has been raised by Council of Governors that with the suggestion from Westminster that the future of Council of Governors may be under a question as to the sustainability. The reaction in some other trusts has been that Council of Governors have been slow to want to undertake some of their duties, or they've been quite vociferous in terms of the work that they're doing to prove their worth. And Brian and myself really agreed that we should just carry on as normal, because rather than speculate what might be coming down the track or what might happen in several years' time, and it probably will take that long in terms of changes to come through. We're very fortunate we've got a good relationship with the governors. They're undertaking good work and cooperating with us in terms of moving the trust forward, and that we really need to put our shoulder behind that and maintain that momentum. And so that is our intention. And the only other thing to say that we've got an update from the executive search company later this week in terms of the search that they're undertaking for the new chair for the trust. And so we should be getting an update on Thursday afternoon in terms of how that exercise is going. But it's currently on track for us to be able to make an appointment before year end. Pretty much on governors. Any other business from anyone? No. In which case, the date of the next Public Trust Board meeting is on the 11th of November. Otherwise, we'll consider a resolution to exclude the press and public from the rest of the meeting, which will be in committee. Just looking at the time, it's 5 to 12 now.